Hello, my name is Sarah Kraft, and this is my video presentation for the case connections for Unit 4 of Medical Biochemistry. I chose to work on case 2 and 3. Let's begin with case number 2, which reads, a 4-day-old infant, patient A, is being followed in your clinic. Her birth weight was 5.9 pounds, and the pregnancy and birth of vaginal delivery were normal. Results from newborn screening demonstrated a phenylalanine level of 6.6 milligrams per deciliter, the normal range being 1 to 2 milligrams per deciliter. A presumptive diagnosis of phenylketonuria was made and additional samples were obtained for further analysis. The parents deny a family history of PKU. As a consequence of this presentation, which amino acid may become essential? Well, those with PKU must adhere to a strict diet in which they cannot consume phenylalanine, because they cannot properly metabolize it. Tyrosine can be synthesized in the body from phenylalanine, but because those with PKU cannot consume products with phenylalanine, tyrosine will have to be consumed in the diet, making it an essential amino acid. Foods that contain tyrosine include dairy products, meat and fish, some grains, and nuts. These are foods that those with PKU must limit or avoid, so tyrosine supplements are prescribed to ensure the patient is getting enough. The next part of the question reads, phenylalanine dietary restriction therapy was initiated at 14 days of age with good response of plasma phenylalanine levels that dropped to within normal range. What are the potential causes of the presentation of phenylketonuria? The primary cause of PKU is essentially the misfunction of the phenylalanine hydroxylase enzyme, which is responsible for the metabolism of phenylalanine. This malfunction is almost always caused by a mutation in the gene encoding for phenylalanine hydroxylase. When the phenylalanine hydroxylase enzyme cannot break down phenylalanine, it accumulates in the body and brain and can cause neurological symptoms, including seizures, psychiatric issues, and mental disability. There is another rare form of PKU, BH4 responsive PKU, also called BH4 responsive hyperphenylalanemia, or HPA, that occurs when there are mutations in the genes responsible for the production of BH4. BH4 is a necessary cofactor for phenylalanine hydroxylase, and therefore, if there is an issue with BH4, phenylalanine hydroxylase cannot work efficiently, further leading to the buildup of phenylalanine. Some patients with PKU have been shown to be BH4 responsive, meaning that when these patients are given supplemental BH4, their phenylalanine levels decrease and BH4 can act as an effective treatment. BH4 treatment is not effective for every patient, and effectiveness usually depends on the specific genetic profile of the patient. The third part of the question reads, another infant, patient B, is also being evaluated for suspected PKU. BH4 loading tests are performed on both patients and the results are presented below. How would you summarize the results of this test for patient A and patient B? Because phenylalanine levels begin to drop after BH4 loading in patient B, this patient likely has BH4 responsive PKU, and treatment with BH4, along with the PKU diet, will help to keep their phenylalanine levels down. Patient A likely has classic non-BH4 responsive PKU, as B4H loading did not lead to metabolism of phenylalanine, suggesting there is a malfunction of the phenylalanine hydroxylase enzyme in this patient, and the patient will need to follow the strict PKU diet. Let's move on to case 3, which reads, a 47-year-old man presents with severe pain in his right great toe. He is unable to bear weight on his right foot, and there is no apparent trauma. He reports the pain started last night and continued to increase in severity. Based on his physical exam and laboratory findings, he is diagnosed with gout. Gout can be caused by several different mechanisms, and blood samples are drawn and urinalysis is performed. The results from this individual are listed below, and they show an elevated plasma urate level and a decreased urinary uric acid level. We are then asked, what is the best explanation for the presentation of gout in this individual, and please explain why the other choices are not consistent with the data, or what additional information you may need to decide the root cause. Option 1, overproduction of purines, is not the best answer in this case because the data tells us nothing about the level of purines in the patient. Although overproduction of purines could lead to gout, There is also a regulatory step in the synthesis of purines, so this conclusion is unfounded at this point. Von Gehrig's disease can lead to an overproduction of purines as a result of overproduction of the substrate for purine synthesis. However, the many other symptoms associated with this disease would likely have presented sooner in this patient. The data we are given does not give us any insight into the level of purines being produced, and therefore we cannot make this option our conclusion without further tests, including a purine panel. Option 2, decreased salvage of purines, could be a cause of increased uric acid, but is not a conclusion that we can make based on this data. If purines were not being salvaged at a normal rate, it would lead to more purines to be degraded and therefore lead to higher uric acid levels. So, while this option could lead to increased serum uric acid levels, a purine panel test would still be needed to confirm this, along with an analysis of the patient's adenine or hypoxoxanthine guanine phosphotransferase or HDPRT enzyme activity, which are involved in purine salvage, and a deficiency in these enzymes could lead to gout. Lesch-Nyhan syndrome is characterized by a deficiency of HDPRT and leads to gout, but symptoms usually present early in life, so this is not likely in our 47-year-old patient. Option 3, decreased urinary excretion of uric acid, seems like the best choice based on the data we are given. The data shows an increase in uric acid in the blood and a decrease in uric acid in the urine, suggesting that excess uric acid is not being excreted, suggesting hypouricemia and making option 3 our best choice in this case. It would also be useful to ask the patient about his alcohol consumption, as heavy alcohol consumption has been linked with increased gout symptoms. It would also be useful to find out more about the patient's diet in order to better understand the most likely cause of his gout. The second part of the question reads, after further discussion with the patient, he tells you that he recently switched from diet soda to regular soda because he read that the fake sugar diet soda was bad for him. He tells you he drinks between 4 and 5 liters of soda a day. Note, the primary sugar in most sodas is fructose or high fructose corn syrup. What is the potential impact of this dietary modification on the presentation of gout? There is a known correlation between the development or worsening of gout symptoms and the consumption of excessive amounts of fructose. In fact, one study found that men who consumed 2 or more servings of regular soda a day had an 85% higher incidence of gout than men who rarely or infrequently consumed sugary soda. Fructose consumption has been seen to increase levels of uric acid in the blood due to increased synthesis and degradation of purines. Fructose also increases the degradation of ATP to AMP, AMP being a precursor acid, further contributing to gout symptoms. Fructose may also further contribute to gout, as high and continuous sugar consumption can lead to insulin resistance, which can contribute to elevated levels of uric acid in the blood. The patient should switch back to diet soda, as diet soda does not have fructose and is not linked with the worsening of gout symptoms. The patient may also be urged to switch to water or unsweetened beverages. Based on this new information given by the patient, the cause of his gout may be partially caused by the overproduction of purines, as well as the decreased excretion of uric acid. Thank you for taking the time to watch this presentation. Following are a few brief slides showing my references.